Hope you all had a very informative first session. Myself, Dr. Aarti, welcome you all to the second session of today's Gold webinar, RM Quest and Then. I want to mention this quote said by Dalai Lama 14. When you talk, you're only repeating what you know, but if you listen, you may learn something new. With this note, we move on to the second session by our awesome speaker, Dr. Mahalaxmi ma'am, who's going to speak on the topic caste gold restrictions. Now I call upon Dr. Arun to introduce our honorable speaker, Dr. Mahalaxmi ma'am, who was also his postgraduate mentor.
Good morning, one and all. I welcome you all for the second session of today's program. I am privileged and happy to introduce our second speaker and my mentor, Dr. S. Mahalaxmi Madam, to this session. Madam has completed her post-graduation in conservative dentistry and endodontics in the year 1986 from Government Dental College, Ahmedabad. She has been in academics since 1919. Dr. S. Mahalakshmi Madam's achievements were organized the first ever 22nd FODI and 15th IES annual conference in Malaysia, conducted the first microscope program in the year 2008, conducted the first national scientific model competition for the postgraduate students in the year 2009. Also organized two video conferences, one from New Zealand and one from Canada during this two-day program. She was the president of Federation of Operative Dentistry of India for the year 2008 and 2009. Dr. Mahalakshmi conducted the 11th Root Summit and International Endo Meet for the first time in India in the year 2014. Dr. S. Mahalakshmi chaired the scientific chairman of the 10th ISPRP conference held in Chennai in the year 2017. Madam won the prestigious award Professor J.G. Kannappan Award for the best research article published in IJDR in the year 2016. She is currently an international board member of AMED. Dr. S. Mahalakshmi Madam's areas of interest dentistry, lasers, occlusal rehabilitation and complex restoration, and nanotechnology in dentistry. Dr. S. Mahalakshmi is member in many national and international associations like Indian Association of Conservative Dentistry and Endodontics, Indian Endodontic Society, Academy of Microscope Enhanced Dentistry, American Association of Endodontics, International Association for Dental Research, and Indian Dental Association. Madam has been a speaker in various national and international forums. She has conducted various workshops and courses over the years. Dr. Mahalakshmi is currently heading the Department of Conservative Dentistry and Endodontics at SRM Dental College, Chennai since 2006. She has more than 50 publications to her credit. Majority is in indexed and high impact factor journals. She has authored a textbook titled Materials Used in Dentistry in the year 2013, published by Walter Kluwer in India, which is highly acclaimed by faculty and students all over the country and is being adopted as the standard textbook for dental materials subject in many institutions across India. Madam also has DST funded collaborative project under her wing for which she is the principal investigator. She is registered PhD supervisor under SRM University and is guiding PhD students under her at present. Madam has undergone extensive training in the use of dental operating microscope and has been using it successfully in her practice for the past more than 10 years. Currently, Madam maintains an exclusive laser and micro dentistry practice in Chennai. Apart all this, as a mentee, Madam is a good teacher, good mentor, well-wisher, cool and good-hearted person. We welcome you, Madam, for this second session.
Thank you so much, Arun, for that, I think, exhaustive introduction. I think you have combined 2, 3 together. Anyway, can I share my screen?
Yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah, one second. I'll just move this up. Okay, now is it visible?
Yes, ma'am.
Yeah, right. At the onset, I would like to thank Dr. Baby John, Dr. Yadav Chakravarti, and Dr. Arun for inviting me to be part of this wonderful program at Vinayaga Mission Shankaracharya Dental College. And it indeed was a pleasure to also meet Dr. Shabri, even if it was virtually. after, as he said, he was very correct. It was 2007. After that, I'm meeting him almost after 13 years. My topic today is on cast gold restorations. But before I start, I would actually like to dedicate this entire lecture to one person. His name is Dr. Roberto Maganales Ramos, who's practicing in Mexico City, in Mexico. And he's just a Facebook friend of mine. But when I approached him, I messaged him that I want to use some of his lovely restorations, cast gold restorations that he posts on Facebook. He readily agreed. You can use whatever you want. So I have a lot of photographs of his, apart from other pictures. So I would like to dedicate my lecture. So remind us that why gold restorations, and that too when we have so many options of aesthetic restorations, why that gold has been used for more than 2,500 years, and all of a sudden why gold into our mind, that is what it just comes to our mind. But I think as Indians, this should not be our thought process. Actually, we Indians, we love gold, right? So when we for everything we flaunt our gold, outright, and it's not only that women, even men do that, and men love gold too. So even though many 90% of the men don't flaunt it, but they still they love. We all love gold. So teeth as well, even in the anteriors. Look at this woman. She is from Kazakhstan. And in Kazakhstan, it is the, it's a norm for women to have gold caps on their teeth, on the front teeth. It is supposed to be, but not that. Even now, even today, I think people just want to flaunt their wealth, or, in various forms. They have gold, they have, gems, precious gems, installed on their teeth. So this is how it has been. And this is not something, from the net that I picked up. A few years back, I visited South Africa, and there I saw so many people having gold, inlays on their front teeth also. If you can see this woman, she was a waiter in the restaurant, and she was very shy to take a picture. I couldn't force her to take a picture of her mouth, so I asked her to pose with me. And you can see the gold inlay that has been placed on the front teeth. And I saw this with many people in the African subcontinent. So so it is not something new to dentistry, I would say. So so then, why are we discussing gold? Now, this is another reason for both. We have so many aesthetic options of both direct and indirect. And so we Indians cannot do away with gold, right? So the proof here it is, that is a webinar being conducted by VMDC College, and inviting Dr. Balagopal and me to speak on gold. So, but then before I start the discussion today, I would like to have a couple of disclaimers. Sorry. One is that I do not claim that my presentation is going to be complete, and please forgive me if you do not find what you're looking for. So my topic today will be on 4 aspects, broadly into these 4 aspects. The material, with little short discussion on materials, the advantages, disadvantages, and preparation guidelines for both. I'll be mostly covering on the intracoronal cast gold restorations, and of course some clinical cases, and with a little bit of history, since gold has been for so long. And I'm wrong to say that it is little bit of history, because history has a long, gold has a long history. And it is mostly in the form of these gold wires that were, used to hold teeth, artificial tooth-like structures for replacing missing teeth. So these are all evidences that were there. But when you see, when I will not go into the full details of the history of gold, but as far as cast gold restorations are concerned, the Philbrook was the first, actually, in 1897, who gave the concept, forming a wax pattern and then converting it and making a mold of it and then converting it into a gold alloy. Much before Tegart brought his casting machine into existence. But then it was him, Dr. W.H. Taggart, who introduced the lost wax technique for cast gold restorations, and he custom made a casting machine, which is the principle of casting machines even today. The open casting technique is still the same principle is being used even today. Now, seeing that these castings were made, now what by this machine ended up being small. So it was J.G. Lane who said that, attributed the investments and all that. And where, when you heat it up to 750 degrees and then it expanded and it compensated for the casting shrinkage. The other one is E.S. Van Horn. He was a precursor for thermal expansion. So there's so much to talk about in history, but then I don't want to sound it like a lecture or a seminar. So we will go back to, the question why, right? Why do I need to have gold restorations? I'm coming back to that again and again. Why do we need to have so many, when we have the option of so many aesthetic options? Especially in the anteriors and in this, the surfaces which are visible in the smile and the laugh windows, probably the choice will be a tooth-colored restorative material. But when it comes to the periodontium and gingiva and the periodontium, actually the periodontium and the gingiva loves gold. If you see even a well done, ceramic, well polished, well glazed ceramic restoration, shows this sort of a gingival marginal irritation. It causes mild gingivitis. And of course, we have to also take into account, but a well-polished gold restoration is actually, it actually brings a smile to the face of the gingiva as well. Of course, here we have to take into consideration the biologic width, where we need to, violate the biologic width. So compared to direct restorative materials, where it will be difficult to achieve a perfect finish and smooth areas in the subgingival areas, a well-polished cast gold will give a smile to the gingival tissues. So moving on to where all can we give these restorations? As I said, large restorations, preferably where you have to build a proper contact and contour, you need to give, you can, see the first choice should be gold. And most of the indications that are for cast restorations will also apply, for cast restorations will also apply for gold castings also. Okay, so any crown and bridge work with metal alloys, the first choice should be gold. Indirect restorations, they have better control with the contours, the proximal contours and the contact. And also in case where there is a full arch occlusal pattern which has to be recreated, then gold restorations can be easily done. In the sense, even other restorations, but finishing will be better with gold restorations. Now, lesions that have subgingival, lesions that have subgingival caries, and it has difficulty in isolation, as I said before, so that the time taken for the seating of an indirect restoration is much lesser. So the chance of contamination also becomes much less as when you compare it with the direct restoration. And also another aspect that you need to see in subgingival lesions is that the contour of the tooth at that level is very flat. So we need very thin margins, and due to malleability of gold, it is easier and it can be really made into thin, and you can even burnish it well and to adapt it on the subgingival margins. So you see for this, just to give a where and all you can use a gold restoration. If you see this tooth, the lesion it's a failed composite restoration, and you can see how wide this area is. Now, to build it up as a direct restoration, to isolate it and give a proper contact band, even if it is an anatomic band, it is really difficult to give a proper isolation, to give a proper separation of the teeth, and to maintain the contour and the contact. And in this case where you have two adjacent cavities where giving a proper contact and contour in this case also becomes very difficult. So these are ideal situations where you can go in for indirect cast restorations. And also you can like these two. So you can also think of your considering cast gold restorations as an alternative when you have to replace multiple failing direct restorations. Okay, so with another, you need to replace it with another series of direct restorations. Instead of that, you can directly do a cast gold restorations and obtain proper results with these. Another aspect where we can use is exclusively in the case of maxillary and mandibular second molars, where full coverage is required, because there will be much less plaque accumulation which is associated with the gold restoration as compared to your zirconia or your ceramic restorations, wherein even the patient can easily maintain the crowns. Also, you can use the gold exclusively in cases where you have to manage dental erosion. Now, in this, cast gold is actually the best suited due to the favorable wear characteristics of these gold restorations, because, as you know, gold has equal wear as enamel, and it is between enamel and dentine, as Dr. Balagopal said. So it has a favorable, it's a favorable opponent to a natural tooth. So it does not wear away the natural teeth when it is given as an occlusal restoration. So what will happen is when we give cast gold, it will act as a centric stops, and these are maintained for long term. And while we eliminate the lack of predictability that comes from bonding your to a compromised tooth substrate, as an erosive lesion is already compromised in terms of bonding. So moving on to the advantages and disadvantages, most of the indications now becomes the advantage. And of course, the disadvantage, apart from the aesthetics and the cost factor, will be extensive tooth removal, where for want of retention and resistance form, and then one more appointment for cementation, and also the problems that are associated with the cementation. All these are the disadvantages. Now, moving on to the material aspect, there is the noble metals that are used in dentistry. Mainly, it is gold, platinum, and palladium. And they are considered to be noble. Why? Because their surface reactivity is very less, and they are highly resistant to tarnish and corrosion. And probably the only reaction that happens is with sulfur, where they react easily with gold, and it forms the sulfides. Okay, so otherwise, noble metals, if they have more than 25% of weight, it is called a noble metal alloy. And there are different categories of these gold alloys based on their nobility, as high noble, noble predominantly base metal alloys, and another classification based on the most common alloy that is present in the most common metal that is present in that alloy. And as far as pure gold is concerned, we always talk in terms of carat. I think we all know what carat means. It's 24% is considered as 100% pure gold. So we have out of 24 carats, how many carats it is, and fineness is again in terms of 1/1000. And gold also is generally classified into 4 types, depending upon the gold content. Gold alloys are generally classified based on the gold content, which decreases as the type of the alloy increases. That is from 83%, it reduces to 56% with type 4. And as the gold content reduces, your the softness also reduces, and the alloy becomes much harder. So basically the type 1 and type 2 are the ones that are used for our intracoronal restorations, because we want it to be soft so that we can burnish it. So it has to be ductile and malleable, so that burnishing is much easier. And type 3 and type 4 are basically used for crowns and short-term span bridges and long span bridges. So alloys are also classified based on their three main components which are present in the gold. Also, in another type of classification is like, suppose the alloys are three main components of each alloy. For example, it will be gold, palladium, silver, and then palladium, silver, tin. Or some base metal alloys you can tell as nickel, chromium, and beryllium, then chromium, cobalt, molybdenum. All these are also the ways in which these gold alloys are classified. Now, whenever we talk about gold alloys, there are three main aspects that you have to think about. One is ductility, malleability, and elongation percentage. Now, these are all associated with both high with the type 1 and the type 2 alloys. Now, percentage elongation is the measure of the ductility of an alloy. So, alloys that are used for intracoronal restoration should have an elongation percentage which is higher, so that they can be easily burnished without any fracture. Now, addition of small amount of iridium in these alloys will actually, we can improve the ductility of some hard alloys. So in type 3, if you want, type 2 and type 3 can be, as I said, as the gold content reduces, so the ductility and malleability of the gold is lost. So type 2 is not as malleable as type 1. So when we want to increase the ductility or elongation percentage of these, very small amount of iridium or even ruthenium is also added, up to a percentage of 0.005%, which will act as grain refiners because of their high melting point. So, and these will actually help in increasing the malleability of type 2 and type 3 hard alloys. Now, another aspect is precious. Now, we have heard of precious metals, precious alloys, and noble alloys. Now, as far as metallurgy is concerned, there's no difference between both. Both are, but in industry, when we talk about precious alloys, that means it has to contain silver. So, because silver is not considered noble in dentistry, because it corrodes easily in the oral environment, moist environment. So the term noble and precious cannot be used synonymously in dentistry alone. Now, as I said, various ways of strengthening gold alloys. We were talking about how to increase the malleability of the harder alloys, but how to increase the strength of your gold alloys, so type 1 and type 2. Type 1 is hardly used nowadays, but type 2 gold alloys are the ones that are used for casting of inlays and onlays. So how to increase the hardness of these by addition of other noble metals and also the addition of copper. Now when copper, the platinum also is as hard as copper, but when you add copper, it strengthens the alloy through solid solution hardening. So this can be used and we can achieve grain refiners again. To a certain extent, though they do not contribute to the hardness of the alloy very much, they can be used to improve the overall strength of the alloy. So today we are going to talk more on inlays and onlays, but there has been a change in terminology. I think everybody as students, and even even if you're a faculty or a practitioner, you will know what an inlay or an onlay is. Before we used to say that inlay as an intracoronal restoration that will cusp. It may or may not cusp one or more cusp, but not all the cusps. Whereas onlay was supposed to be and intracoronal restoration that will cusp all the, will cover all the cusp. But then now with the introduction of all these aesthetic options of, indirect restoration, we have these the restorations that cover all the cusp are now called as overlays, whereas onlays are in intracoronal restorations that cover even one cusp also is now called as an onlay. So there's terminology, a slight change in the terminology nowadays. So moving on to how, what are the basic principles of cast restorations? It's the same. It's the same as for any other tooth preparation. The main, as I said, is conservation of tooth structure, right? Even with cast restorations, with tooth preparation for cast restoration, we still have to follow the same principles. Here, we need to minimize the removal of tooth structure, but also we need to protect the remaining tooth structure. Right? Okay. So, in terms of protecting the tooth structure, sometimes we may have to remove, which we may have to even remove weak tooth structure which is present in terms of giving a cusp capping, or we need to give an overlay sort of a restoration. So, and resistance and retention forms both are closely correlated with each, interrelated, because you can never, as we may give different resistance form and the retention form features, but clinically they both actually are very interrelated. Now, however, they're actually affected by 4 different factors. One is the ratio of the applied force on the force that is being it is subjected to over the surface area of the restoration, and then your final geometry of your restoration, the material that you use for luting, and the surface texture of the final restoration. See, so when we do an inlay cavity preparation, the general rule is to maintain the long axis of the burr parallel to the long axis of the tooth. Okay, so now we have these specific burrs that are used for inlay cavity preparation, and as you see, it is only 0.5 to 0.8 millimeters. So you can have really very what do you call it? A very narrow preparation for your occlusal preparation, occlusal part of the preparation. And the only aspect that we need to take care is the isthmus area, where there should be a gradual increase in the width when you go from the occlusal to the proximal pattern. And we need a minimum depth, minimum width, which will be roughly around 1 millimeter. When you use a 0.8, it will be the minimum width will be roughly around 1 millimeters. And the main aspect here we have to note is that it should need to have a definitive margin, so that when you capture these margins in the restoration, in the impression, and send it to the lab technician, he will be able to give you a perfect finish. Now, one thing which we need to take in, I was mentioning about staying along the long axis of the tooth. Now, one aspect that we need to remember is long axis of the tooth, right from the occlusal to the apical to the root. Generally, we forget the inclination of the tooth within the arch. For example, in case of this lower premolars and molars. Now, this tooth inclination, if you see, it is very much inclined lingually. So when you prepare the tooth, you need to have an inclination that is lingual as well. Cavity will be right in the center of the tooth. And one aspect which I would like to really emphasize is the use of a Williams probe. We generally tend to calculate with our eyes how much should be the depth. We it is ideal. Sometimes we overshoot or we underestimate and we prepare. So it's always better to use an Williams probe to see the depth of the cavity, not only in the occlusal, also on the proximal, so that even of course this is not possible in a patient, but then you can achieve a sort of a corrective measurement in case when you use a Williams probe. Now, when we talk about inlay preparation, the main thing we have to see is the path of insertion. This preparation path, both for path of insertion as well as the path of draw. That is, path of draw will come when you have to have your wax pattern and create a wax pattern and you have to remove it. At the same time, insertion comes in when you have to place the prepared inlay into the cavity. So this path, this should be a single path of insertion and draw. It should be also opposite to the occlusal surface. So it should be direction is perpendicular to the occlusal surface. And it also follows the long axis of the tooth again. So this will ensure that the cavity does not have any undercuts. When we come to the most important aspect in the preparation is your axial walls in the cavity walls. Now the pulpal third of the cavity wall, that is this pulpal third of the cavity wall, which is about 2/3 of the total cavity wall, will be almost nearly parallel, and you can up to 2 to 5 degrees is 2 to 5 degree taper is ideal, but clinically it is a little difficult to achieve. So up to 8 to 10 is also fine. So that we have to make sure that there are no undercuts. Now, once you come to the occlusal 1/3, this is where you need to give a long bevel. That is the bevel that encloses the enamel and part of the dentin. And this has to have an angulation of about 30 to 45 degrees. Now, 30 is in case where the cavity is very narrow, so that in narrow cavities you need to just give a smaller bevel. But as the cavity width increases, you need to give the bevel. The bevel becomes larger, and it becomes more. And this angulation will also help in 3 ways. One is it will accommodate bulk of the alloy in this area. Okay, and also it will bevel the enamel rods that are present within that cavo surface margin that are inclined towards the cusp, and also it will increase this bulk of the metal, the alloy that is increased will be able to resist the stresses that are induced at the more towards the inclines of these cusps. Okay, so but when we have the deep or steep cuspal inclines, and then we need not. Sorry, I had put some arrows. I forgot to put them. So when we have a steep cuspal incline, in that case, because of the inclination of the enamel rods towards the inner, in cuspal incline, in this incline, your cavity preparation can be parallel, and you need not give this occlusal bevel at all. Okay, now the depth and the depth and the width of this cavity actually play a very important role in the flexural strength of this particular tooth, unprepared tooth. Okay, so it also contributes to the fracture resistance of the tooth. So the depth of the cavity, in other words, the height of the axial wall, okay, in relation to the length of the tooth, will predispose the cusp to fracture. Now, if you see, then if the depth is ideal, then you need not worry about the flexion. But as the depth increases, this walls, they become very weak. So there will be chances of flexion happening. And this also, or not only the depth, as the width also increases even more, the cusp tend to flex more as the width increases. And also more so in case of an MOD cavity. So there is a drastic reduction in the fracture resistance of these cusps and they are predisposed to fracture. And if you see that class 1 isthmus, the fracture resistance reduction is about 11 to 52%, whereas when it is proximal one side proximal occlusal cavity, then the reduction is up to 57%. And when it comes to MOD, then the reduction in fracture resistance is from 36 to 61%. We need an in the width proximal. So the gradual increase in the isthmus area. This is what is an ideal situation wherein you will provide the proper retentive features, and by giving a slight dovetail, you create a retentive feature for this restoration as well. Now, when we talk about the proximals, when we talk about the proximals, the main point to remember in a proximal cavity is the slight divergence that we give towards the outer wall. Now, here again, we have two parts, that is the inner half and the outer half. The inner half towards the axial wall, that inner half which is towards the axial wall will be near parallel. This is by this orange line, it shows that it's near parallel. But when you go towards the outer half, that is more towards the gingival cavo surface margin, there should be a slight divergence. So this gives this inner part will contribute for the retention of the restoration, while the outer part will give, while the outer half will provide a proper contour and also will provide a preparation path for insertion and proper contour of the proximal surface. Now, in all these, especially with cast gold restorations, the main aspect is the bevel. We were talking about the occlusal bevel. Now here, when we talk about the bevels, it's an abrupt incline between two surfaces of a prepared tooth between the cavity wall and the outer cavo surface margin. Okay, and it can be within the cavity, it will be within two surfaces within the preparation as well. And now these angulations, if they are other than 90, then it is actually called as a bevel. These bevel will contribute both to retention and resistance features, right? So like say suppose in case of a margin, it will allow the gold to allow it to be easily burnished so that it will reduce the amount of cement exposure. It will, in case of gingival, so it helps us for retentive feature, whereas in gingival seat, if you have a cavo surface margin, if you bevel, it will remove the unsupported enamel rods and contribute to resistance form. So there are 6 different bevels that are used in cast gold restorations is preparation. The partial bevels, the short bevel, the short bevels, which involves only the enamel, the long bevel that I was talking about. A full bevel is definitely not given, but you can say that your cavity preparation with a slight divergence of the walls is actually one of, we can say it as a full bevel. Both counter bevel and the hollow ground bevels are used in case of only preparations. So, the general principles good. Adequate depth, that is ideally it should be about 1.5 to 2 millimeters. The minimum width should be 1/4 to 1/3 of the intercuspal distance. Then you have to have definite rounded, it has to be definite internal line angles, but it has to be rounded at the same time. Then you have the actual pulpal line angle that has to be beveled round. Then you need the gingival seat with a perpendicular to the cavo surface margin. It has to have a definitive seat so as to prevent any migration, and then and it has to be have to have a width of up to at least 0.8 to 1 millimeters. Right now, at the end of all this, the one aspect we actually forget is the enamel wall. Now, finishing of enamel wall is really very important. in all the restorations. It's not only in cast restorations, in all the restorations, because enamel has to be supported by sound denting. And enamel rods at the cavosumus margin, where you feel that it is not supported by sound denting, has to be beveled or removed. Okay. Now when we consider an inlay, and when do we consider preparing this tooth, for particular tooth for onlay? Now, when the width of the cavity increases more than 1/3 of the intercuspal distance, and if you feel that the functional cusps, especially, they are very thin, then we need to bevel and include that cusp in your preparation, and that is where you cap the cusp. And then, if the length to the width ratio is like the length to the width ratio is more than 2:1, then we need to cusp the functional cusp. Now, also, if you want to change the occlusal pattern, you want to increase the so that it matches the opposing tooth. In that case, we need to consider onlays. Now, an ideal ideal thickness that we need to consider is 2 millimeters, especially on the functional cusp area. Now, this 2 millimeters, it has to be you will have uniform thickness. So this uniform thickness will help in better occlusal loading. It bears the occlusal loading better if the material thickness is uniform. Now, okay. So when you see the occlusal pattern, it has to follow the contour of the outer surface. So when we prepare, we make sure that the occlusal is not like a dining table, but then we need to follow the contours of the occlusal cuspal inclines and as well as the groove. And another important aspect is the transition. Transition should be uniform, and this transition should at least be 2 millimeters for adequate retention resistance. Okay, and when you see around the tooth from the occlusal view, you need to have a definitive stop all around, which will be now this is called as the circumferential tie. So it is a 360-degree peripheral margin anatomy, which is termed as a circumferential tie. In case of a crown, it will go around the tooth, and in case of an onlay, it will go around with the cusps wherever is required, and it will also encompass the cusp it will be within the cusp wherever it is included in the cuspal design. So when we talk about any tooth preparation, the basic principles have to be followed so that we achieve not only structural durability, but also marginal integrity. So all these aspects that we were talking about, all this will provide both either structural durability or will contribute towards marginal integrity. And so that the entire preparation needs to be followed. Now, apart from that, we have to have a good laboratory support, because any preparation that you do, any good restorative preparation that you do, you need to have a good laboratory support. Unless the lab technician gives you a good result, you cannot give justice to the patient. But then that depends upon you again, because you need to give a good impression that not only captures the details of the restoration itself, but also beyond the margins, so that the technician knows exactly where the margin should end. Okay, and another aspect that needs very important is the occlusion that you need to provide, because you're the one who's seeing the patient. The technician does not have any idea about how the patient occludes. See, the occlusal, the bite registration is a must when you do any cast restoration, any restoration, even any indirect restoration, I would say. So provide, if you give it this, all this, and you need to have a good lab technician who will do a perfect stuff and give you, then he will be able to make a proper gold restoration and give you a crown that you can fix. I'm sorry, that was a crown, but this is a inlay. So you can get a good contour, well matched, occlusal anatomy, and also the contact with the adjacent tooth. So this can be achieved with good preparation from your side, good lab support from the technician side. So moving on to some clinical pictures, I'll show some of Dr. Ramos's preparations, and this was it had to be replaced. But then if you see this was done 36 years back. You can hardly see any secondary caries. It's only that the cement layer has been a little destroyed. Apart from that, he could well achieve a good preparation, and this was then done. Seroma restoration was done later. Now they had to replace this mainly because the tooth had drifted and there was an open contact here. So there is another gold onlay here, which is again maybe the same 30 plus years. Now this is again another picture of Dr. Ramos. Here your comparison is between your gold crown and a zirconia onlay. So the margins, the finish that you get with a gold margin is much better than any restorative material because of the fact that you can burnish it well, and you can the life of such restorations is like unimaginable. 15 years, 30 years. He is a dentist who is 70 plus. So he has almost 40 years of cases that he can show. And if you have the time to go on his Facebook page, you can see the type of restorations that he is doing. And even today, he not that he has not changed. He is even today he does love very good direct composite resin restorations and ceramic indirect as well. Equally good. This is another one which is about 50 years old. You should really appreciate the design of the restoration, the occlusal pattern and everything that and also the patient's motivation to keep it plaque free. So that is what contributes to. So he says that probably at the most I need to just do a little bit of polishing to bring back the luster. Otherwise, it's as good as new. And same patient, he had the opposing arch on the upper side, where he has given an ceramic onlay, and this is the onlay, gold onlays, and see the margins. So these are the margins with ceramic, and you can see a slight discrepancy in the margin, very minimal though. Whereas with gold, because of its burnishability, even those slight mild gaps can be very well burnished. And these again a series of gold inlays done by him about 35 years. The last case of his, where it's a little out of the box thinking, I would say, where a gold in cast gold onlay, there was a small defect on the tooth after many years of service, and instead of replacing it, what he did, had the cavity and did a direct filling gold here. So anything is possible, right? So you must be wondering that I'm always showing only cases done by somebody, we can't do in India and all. So I thought I will give you some more, cases which are done in our country. This is a gold inlay done by a very good friend of mine, Dr. Ida. She's the dean and professor and head in Goa Dental College in Goa. She did this at the initial days of her joining college. That was, I would say, in the year 1988. So at that time, she had done it for one of her staffs, and I asked her to take a picture of that and send it to me. So this was this actually, I think she must have sent it to me about a year ago, and then requested to take an X-ray also. So you can see there is absolutely no, though there is slight ditching of the margins, I would say, slightly, but absolutely no secondary decay anywhere. And that's the longevity that we always think about. No, patients are also kitna chalta hai, like they'll ask how much it will go. So the longevity we can't, of course, predict, or we can't even tell them, okay, we are giving a warranty or a thing. But then these have good results, and they have now, as Dr. Balagopal was talking about Dr. Anil Chandra. Now in KGMC, again, these are a couple of cases done by his students in KGMC Lucknow. This is a gold inlay, and to add up to Dr. Balagopal's, that they do gold foil restorations. They do routinely there, because the gold foil restoration is one of the exercises for their MDS examinations. It's a little different than the other colleges, but they do follow that for so many years. And another one from Chennai. This is from Dr. Prakash. This is a gold gold metal fused to ceramic. The metal used here was gold. This was done in a lab which I had about a few years back, and till few years back, and this was done 15 years ago. And I requested him to take a pic, and he then requested his patient to take one. So the patient actually sent this pic of his. So this was about 15 years ago. And the gingiva is it's a little I would say not inflamed or anything, but there is a slight change in the margin, maybe a little recession of the gingiva. Probably Dr. Prakash has to see him again and see what is the matter. And before I end, this is my last. So I kept this for the last, because this is my husband's case. And I said, it's always difficult to treat husbands. Okay, not the husbands, but basically a spouse. It's very difficult to treat us, especially my husband, because he has severe gag reflex. So doing a restoration for him, and imagine I had to do an endo, and in 3/7, this was this tooth. Actually, I did it in 2008, and this X-ray was taken in 2011, where I had to do a filling for him, and it's a nightmare to treat him always. And I placed a gold full crown for him. And forget about taking pictures, because anything you introduce in the mouth and he starts gagging. So even taking a radiograph, for the root canal treatment, I had a tough time. And even this radiograph, you can see how it is. So I asked him to take an OPG recently. And you can see the gold crown here. Actually, he went for an OPG for another reason. But then see the gold, the margins, they're so perfect. And no secondary caries. I'm sure maintenance of this thing at the distal most is really difficult for him, because even brushing actually causes gagging reflex. So so this is, I would say, this will be the ultimate reason why we should use cast gold restorations. So with this, I end my lecture, and I thank once again Vinayaga Mission Shankaracharya Dental College for giving me this opportunity, and now I'm open for questions.
Excellent and detailed presentation, ma'am. Really, we were excited to see lots of clinical pictures with gold restorations, and especially your husband's radiograph, which were very influencing for us. Now I request our staff, Dr. Subhashini, to handle over the question and answer session.
Thank you, ma'am. It was indeed an interesting and a very impressive presentation, ma'am, with a clear description of clinical pictures. Ma'am, here we have few questions from our participants. I kindly request you to clear our queries. The first question is from Dr. ND. Does the location of the margin have any influence on the longevity of gold restoration?
It is, I think the location of the margin does have an influence for any restoration for that matter. But I would say that when we place the margin supragingival, and if the patient is able to maintain that area well, any restoration will work. And in case of subgingival margins, and if we do not violate the biologic width, I think the restoration still can hold good. And as I said, gingiva is very favorable to a gold alloy rather than any other material. That is that I can vouch for, because even in patients, those who are not able to maintain that much, because there is always this chance of plaque accumulation within the subgingival area. So in that case, it is better to go for a gold cast gold restoration rather than doing, say, for example, direct composite restoration.
Thank you, ma'am. The next question, ma'am. Can we use white gold as a substitute for cast gold to improve aesthetics?
Doesn't make sense. Like, white gold, again, it's a white metal. It is not tooth colored. So doesn't make sense in changing. And white is basically, they add more of palladium. So palladium being noble metal, it's fine. We can still go ahead and use palladium. But the palladium and gold, they are soluble in each other. So that also is not a problem to use a gold palladium alloy. Basically, the problem will be when, the more you add any other alloy, the ductility and malleability goes up. That is the main advantage of using any gold. And I would, it's easier to for us, to get a small piece of gold from the patient itself, and the jewelry that they make is actually in the south. We actually make jewelry more with copper. That's the reason it's more yellow in color. In the north, they use more of silver to increase the hardness of the. Otherwise you can't your gold. You can't make it into jewels. So when you see that the gold in the north is more whiter than gold in the south, because here we use copper for the alloy, and there they use silver. But jokes apart, doesn't make sense in using white alloy for aesthetic purpose.
Thank you, ma'am. The next question, ma'am. What is the preparation protocol for gold veneer restoration?
Gold veneer is, I'm supposing this is for anteriors.
Yes,
I can't comment on that, because it is not used for veneers, first thing is. So I really don't know, because see, it does not have, the only thing which I can tell is that it does not have adhesion to the tooth. So we need to create some sort of a lock or a sliding joint somewhere to sort of make a veneer. But I would like to know who wants to make a gold veneer for themselves, probably.
Thank you, ma'am. Ma'am, which is the best luting cement for cast gold restoration?
The best luting cement is zinc phosphate, because it does not, see, the gold does not bond to the cement, nor does it bond to the tooth. So we need cement that can be, flow, that has a very good flow. And also it have a micromechanical retention, and its strength is much better. So there is no point in using a glass ionomer in that matter, because though the glass ionomer has addition to the tooth, it does not have any effect on the gold. So the best cement would be zinc phosphate. But in case that the cavity is very deep and you want to use any other for a pulp protection, then we probably have to use a glass ionomer as a base and then do a cavity preparation and take an impression. So the gold will not come anywhere closer to the pulpal tissue. As sir was telling, that at least 2 to 2.5 millimeters. I would say we can even go up to 1.5 millimeters. At least 1 millimeter of dentine is enough to to act as a really buffering. It has a very good buffering capacity. Dentine has a very good buffering capacity. So up to 1 millimeter, it can very well withstand.
Thank you, ma'am. The next question is the filling or seating of cast gold restoration more easier compared to other casting alloys?
Yes, definitely. If we're here, my comparison would be with base metal alloys. So with cast gold, it is definitely easier because you can, if there is a slight discrepancy, say suppose in the margins, around the margins, or in the seating, you just have to use your cleared cardboard or a burnisher nicely to burnish the little areas and then seat it in. So that way it gives a little, compared to a base metal alloy, which is very hard, finishing also is very difficult. So cast gold alloy definitely is much better.
Thank you, ma'am. Ma'am, the next question. Due to more length and width ratio in the cavity preparation, if we switch on to onlay, why can't we involve non-functional cusp, ma'am?
Okay. When I said the functional cast, because we definitely, why not? We need to involve the non-functional cusp as well. The main, the point is here is that the width of the cavity, if it is towards anywhere, even if it's a non-functional cusp, if it is thin, say less than 1.5 millimeters, if you see the thickness, and if the depth is more and you have a really long axial wall, then it is definitely indicative of involving the functional cusp. Now again, in the functional cusp, we cannot give a bevel on the occlusal. That is the only reason in that case, then we need to go in for an aesthetic option. If we have to involve the non-functional cusp, and that one, say in the uppers, it will be the buccal cusp of the maxillary molar. So in that case, we cannot give a bevel and involve the buccal surface. Sorry. So in that case, we probably have to choose a more aesthetic option than gold alloys. But in case of lower molars, even if it's a functional cusp, we can still, even if it's buccal, we can still do a lower molar, because the visibility is much lesser with the lower molars, especially the second molars, rather than an upper first molar is more visible than a lower first molar, I would say.
Thank you, ma'am. The next question, ma'am. Is the secondary flare mandatory to incorporate in cast gold restoration?
Secondary flare is mandatory when your the length of your or the depth of your cavity is more. See, what happens is we need a sliding fit into the cavity. So whenever there is a sliding fit, and if it is a long, you can think of the amount of friction that is going to happen. So even a slight discrepancy will actually, it will not see the casting. So in that case, especially in the proximals, because occlusal is fine because it's visible for us. But when you do the proximals, what happens is invariably when you check with the mirror on the occlusal surface, invariably there will be some undercut or so. So to avoid that, we need to give a secondary flare that again, if you are doing a direct, in exams and all, you need to do a direct pattern for inlay. In that case, you don't need to give a secondary flare. You should not give a secondary flare.
Thank you, ma'am. Ma'am, can you please explain again about circumferential tie and its importance in cast gold restorations?
Okay, circumferential tie is nothing but the shoulder preparation all around. Say in case of a, just imagine a crown preparation. So when you make a crown preparation, unless and until you give a stop somewhere around the circumference, how will the technician know where to stop? And how will the, your insertion also, path of insertion also, when you insert it, how will you know where it is going to end? So that margin, whatever it may be a shoulder in case of a, in a ceramic restoration, it may be a chamfer in case of a cast gold restoration, but it has to be a definitive line, a margin. So that circumferential line is what is called as the 360-degree circumferential line is what is called as the circumferential tie. So that same thing also applies to your onlay or inlay, even inlay also for that matter. But inlay is because the circumferential tie is more to with extracoronal preparation than an intracoronal preparation. So in case of an onlay, when you are out more of the cusp onlays, overlays, then you still have that circumferential bevel that goes around those cusps. I hope this is explanation enough.
Thank you, ma'am. The next question, ma'am. Is cast gold restoration advantageous over direct filling gold?
See, the indications for both are totally different. So you cannot compare apples with oranges, right? So though both are gold, cast gold cannot replace direct filling gold, and direct filling gold cannot replace cast gold. Direct filling gold are used for very small cavities. One is the cost factor. The second is the time taken for the restoration. It's a time-consuming but very exhilarating experience to do the direct filling gold. But then only small cavities is mentally allowed.
Thank you, ma'am. The next question, ma'am. For a crown, what are the brands available and the price to be charged approximately?
See, for the gold alloy, there are very few companies that have come out. Actually, in India, it's now very difficult to get gold alloys. But I think the technicians, if you tell them, they do get it. And even I really don't remember the brand name what I had used, because the last time when I had done it, both the times I had bought the alloy and given. But actually, I really don't remember now. I should actually look into and ask my dental dealer who gave me that. And what else? It was the question. What do we charge? Actually, you can charge as much. Actually, your charges will be very high. Because the gold alloy that you get, the pure gold alloy that is available is around, when that was, I think 10 years back, it was around 5,000 to 6,000 per gram. And you need to use for a crown, I used about 4 grams. That cost around 15,000, 15 to 20,000 that itself. And then you need to go charge the patients more. So in that case, you can always ask the patients to bring their own gold, so that that part they don't have to worry about the cost. So you don't have to worry about the cost of the restoration. But gold restorations are expensive.
Thank you, ma'am.
But then in India, I think we can very easily convince patients, right? These are all gold. They make chunks of jewelry and keep it in the locker, and this is after all a tooth, so that it's there in their body. So I think we can very well convince patients.
Thank you, ma'am. That's all for today's questions, ma'am. Thank you so much, ma'am, for patiently answering to all the questions and sharing your expertise with us.
Thank you.
With this, we come to the end of our question and answer session. I request Dr. Aarti, ma'am, to moderate the rest of the session.
Thank you, ma'am. So we want to facilitate you along with all the awards that you have on your screen, ma'am. We want to add a facilitation also. So now I request our beloved Professor and HOD, Dr. Yadav, to felicitate our speaker, Mahalaxmi, ma'am.
Thank you, ma'am, for your excellent presentation. We would like to forward the e-certificate to ma'am. Thank you, ma'am.
Thank you for the lovely certificate.
Now I request Dr. Pallavi to deliver a vote of thanks.
We are drawing information with start for knowledge. I'm sure this webinar had provided us enough of knowledge of long technique to get it back to shine one. On behalf of organizing team, I, Dr. Pallavi, take the privilege of delivering vote of thanks for today's event. First and foremost, bow my head in gratitude to Lord Almighty for being the greatest universal bonding force of this event. Let me express my sincere gratitude for the honorable speakers of today's event, D.S. Balagopal and Dr. Mahalakshmi, for being the golden material of this event and letting us with their knowledge. Special thanks for helping us in communication and supporting us to organize this event effectively. Our words may not be capable of communicating our sense of gratitude to our esteemed university, Vinayaka Mission's Research Foundation, for its constant support. I thank our chief guest, Dr. D. Sabrinathan, Director Academics, for attending this session in spite of his busy schedule. I'm grateful to our beloved Dean, Dr. Baby John, for motivating us and supporting us through our role of conducting this webinar. We offer our sincere thanks to our HOD, Dr. Yada Chakravarti, for his unflinching dedication and coordination. I'm grateful to my colleagues of this organizing team and technical team members, being the burnish and carvers who are making the shine of this program. My sincere thanks to all the national and international participants for your patience, hearing, and attendance. Thank you, one and all.
Thank you.
Thank you, Doctor.